Okay, this is Dr. Carpenter, and I'm back with you now. I hope you took a little break like I did, and you're coming back refreshed and ready to keep learning. We have two sections left in this program. For this next section, we're going to go over some QME examination procedures, and then following that, we're going to get into determinations of permanent impairment with some discussions of the AMA guides and how to actually provide for permanent impairment ratings for those examinees that do indeed have bona fide peripheral nerve lesions of the lower extremities. So now we're in the examination room and we're getting ready to do our examination on the lower extremities of our examinee, and we're focusing now here on some of the neurologic examination procedures, or I should say procedures involved with the neurologic portion of the examination. And we're going to continue to discuss some of the important neurology and neuroanatomy involved with the neurologic exam, so that your memory is refreshed on what it is that you're actually testing and what specific examination findings actually mean. For example, what does it mean? What does it indicate? What tissues, structures, organs, and even cells are involved when we do, for example, our sensory exam? And what cells and tissues and structures are involved when we do our motor exam? And so we're going to get into some of the neuroanatomy here to refresh our memories about what it is that we're actually testing when we go through these various maneuvers. So with regards to the lower extremity and the neurologic exam of the lower extremity, there's four main components of the neurologic exam. That is our sensory exam, and with sensory exam we're going to be testing primarily for light touch and pain. In the upper extremity, our sensory exam also involves two-point discrimination testing, and I just mentioned two-point discrimination testing here as a reminder to you to include that with your upper extremity exam, but we don't include two-point discrimination testing in the lower extremities because the AMA guides specifically don't make reference to two-point discrimination testing of the lower extremities. So in the lower extremities, our sensory exam involves examination for light touch and pain. The motor exam, we're going to conduct the motor exam by using manual muscle testing of the muscles innervated by the named peripheral nerves. And we'll talk about some principles involved with manual muscle testing. The lower extremity neurologic exam includes testing of reflexes. And I'm sure you typically test the knee jerk reflexes and the ankle reflexes. And we're going to review what the components of the reflex arcs are. And I'm going to demonstrate to you that in order to have normally operating and active reflexes, many structures have to be properly functioning. We'll also discuss some of the little known reflexes of the lower extremities, such as the adductor reflex and the hamstring reflexes, including the medial and lateral hamstrings, and then also the posterior tibial reflexes. And then we round out our neurologic exam of the lower extremity by taking girth measurements in order to detect either atrophy or hypertrophy. And recall that girth measurements are taken at 10 centimeters above and 10 centimeters below the knee joint. So let's talk about each one of these components now, and for this section, let's get into a discussion of the sensory examination. Now, recall with our sensory examination, we're testing the afferent impulses from the periphery up into the spinal cord. And in the periphery, there's two basic classifications of sensory receptors that we're going to be involved with. And these sensory receptors are located in various locations out in the periphery, such as in the joint capsules, such as in muscles, such as in tendons, and such as in the skin or at the base of hair follicles. And the two basic classifications of sensory receptors are, number one, the unencapsulated receptors, and then number two, if we have unencapsulated receptors, then we also have encapsulated receptors. Now, the unencapsulated receptors are a small group. They consist basically only of free nerve endings, and free nerve endings are located in many tissues, which we'll discuss. Then the encapsulated receptors, there's many different types and many different locations, and encapsulated receptors could include such structures as Meissner's corpuscles, such as Ruffini corpuscles, such as Pacinian corpuscles, such as Krauss end bulbs, such as Golgi tendon organs, such as muscle spindles, and these are all specialized receptor endings that detect disturbances or perturbations in the periphery and then send those impulses through the afferent fibers up into the spinal cord. And we're going to be testing both receptor function and the afferent impulses with our sensory examination. And those of you that have the PowerPoint presentation, or if you don't have the PowerPoint presentation, simply refer to your course notes that accompany the program. I have a diagram here that shows two types of afferent neurons and two different types of receptive endings. The first simply is a pictorial diagram of free nerve endings, and the second is a pictorial representation of some type of an encapsulated nerve ending. And typically these encapsulated nerve endings are membranous, typically multi-layers of membrane that detect some sort of deformation, perhaps due to pressure, for example. Pressure could cause deformation of this encapsulated membranous ending, and that could spark a nerve impulses to be generated up this afferent neuron. Now, the afferent neurons that we're dealing with fall into a classification known as unipolar neurons. Now, typically when we think of neurons as having a cell body at one end, an axon coming off of the cell body, and then receptive endings known as dendrites at the distal end of the axon. Well, these sensory afferent fibers that we're dealing in the peripheral nervous system are of a classification of neuron known as the unipolar neuron, and have slightly different configuration. They have their nerve cell body, but the nerve cell body is located juxtaposed, or I should say interposed, between a peripheral process and a central process. And let me explain that. It's the peripheral process that projects from the nerve cell body out to the receptive endings. So with these afferent neurons, these afferent unipolar neurons, the nerve cell bodies are located in the dorsal root ganglion. And in the lower extremities, these dorsal root ganglion are located immediately prior to the exit of the nerve root from the corresponding spinal level. So these dorsal root ganglion are located immediately central to the exit foramen at L1, L2, L3, L4, L5, S1, S2, etc. And from there, the dorsal root ganglia and the nerve cell body sends a central process up the cauda equina to synapse in the dorsal horn of the spinal cord, or in some ascending pathway in the white matter of the lumbar or sacral spinal cord. And we're not going to discuss the ascending pathways of the lower extremity. Those, of course, would be the fasciculus gracilis and or one or the other of the spinal thalamic tracts. That's beyond the scope of this discussion, but suffice to say that the central processes project from the cell body and the dorsal root ganglion up into the spinal cord, and then also from the cell body and the dorsal root ganglion is sent out a peripheral process which then goes out into the periphery of, say, the skin of the dorsum of the foot, for example. And so it's a slightly different configuration. And what we typically think of dendrites as the receptive endings, in this case of these sensory afferent neurons, those dendrites involve these specialized receptor endings, which could include either the free nerve endings or any of the other types of encapsulated specialized endings that we see. So out in the periphery, some of the different types of receptive endings that we'll see at the end of these peripheral processes, for example, could include the free nerve endings. The free nerve endings are unencapsulated, and they're found typically in the epithelial layer of the skin and the mucosa. So typically found close to the surface, and they're responsible for relaying information such as pain, such as crude touch, such as temperature sensations, such as itch and such as tickle, and many references refer to itch and tickle as simply different types of pain sensation. Meissner's corpuscles, for example, these are located also in the skin. Generally, they're located at the junction between the epidermis and the dermis, particularly dense in the fingertips and the lips. And they're found sort of integrated in the papillae of the dermis. And you'll recall from your study way back when you learned about the integumentary system, that just underneath the epidermis is the dermis, and the dermis is raised into folds, multiple folds, that give us what are called the papillae of the dermis, and it's the papillae of the dermis that gives us our fingerprints. Okay, so if you look at your fingerprints are simply due to your epidermis being draped over these multiple folds and papillae in the dermal layer. So these Meissner's corpuscles are simply right underneath the epidermis in the dermal layer, and because of their location, they're very sensitive to fine touch. They're very sensitive to low frequency vibration, and it's the Meissner's corpuscles that can tell you when, for example, you have an ant crawling on your skin. That very fine touch, that the weight of an ant is sufficient to deform this specialized receptive ending, this encapsulated Meissner's corpuscle, that when it deforms, it causes the generation of an action potential in this peripheral process that then gets transmitted up the peripheral process to the cell body and the dorsal root ganglion, and then from the dorsal root ganglion up the central process to the spinal cord for processing. Also found in the skin, particularly in the dermal layer of the skin, and also in the subcutaneous, meaning below the dermis, below the dermal layer of the fingertips, are specialized encapsulated receptive endings known as Ruffini corpuscles. Those are sensitive to touch and also slightly deeper pressure. Pacinian corpuscles, these are encapsulated receptive endings found in subcutaneous tissues and also found around joints and in joint capsules. These respond to pressure and high frequency vibration. Krauss's end bulbs, these are found in the dermis and in the subcutaneous tissue. They're found in the mucosa of the lips, the eyelids, and the external genitals. Also respond to light touch sensations. We have a couple of different types of proprioceptive endings. The first of which is the Golgi tendon organs. These are found in the musculotendinous junction. And these are responsible for giving us our sense of muscle tension, or the amount of loading sustained by the musculotendinous junction. Also, we have muscle spindles. These are specialized receptive endings that reside within skeletal muscles, and these are responsible for giving us another form of proprioception, specifically related to our sense of muscle length, and also the sense of the rate of change of length of muscles. And these proprioceptive endings are interesting. The Golgi tendon organs and the muscle spindles, that is. These are interesting because unlike the other receptors, such as, for example, the Meissner's corpuscle, which gives us our sensation of light touch, such as an ant crawling across your skin, these proprioceptive receptive endings convey sensory afferent information about position and muscle tension and joint angle, etc., to the spinal cord, and most times that information does not ascend the spinal cord to reach consciousness. Most of the processing of that information takes place reflexively within the spinal cord without even reaching consciousness. Now, that's not to say that this information cannot reach consciousness, because that's not true. It can. In fact, if you hold your arms out extended away from the side of your body, and you close your eyes, and you bend your elbows to 90 degrees, you can tell that your elbows are bent 90 degrees because you can feel it. That's what we say. We say that you can feel it. By feeling it, we mean that your brain is receiving information from the proprioceptors in the joint capsules and in the muscles and in the musculotendinous junctions, and all these different receptors are sending information to your brain about the position of your arms in space. But generally, as you go about normal movements throughout the day, in walking and in squatting and in lifting and doing your activities, much of this information does not even reach consciousness. It's either handled reflexively in the spinal cord level, or perhaps even in the cerebellum level. So kind of interesting, these different connections that these sensory receptors have once they reach the spinal cord. For those of you that have your handout materials, I have a cross-sectional diagram here that shows a section of skin, and this is hairy skin versus non-hairy skin, known as glabrous skin. This is a section of hairy skin that shows both the epidermis, the dermis, and then deeper subcutaneous layers. And it demonstrates the variety of different types of specialized sensory receptors just in the skin layer. So, for example, in the center part of the diagram, in the dermal papillae, just underneath the stratified squamous epithelium of the epidermis, we see a Meissner's corpuscle, and you can see that that receptor is perfectly positioned to be able to detect very slight perturbations on the surface of the skin. Other sensory receptors, as you can see, are wrapped around the base of hair follicles. And what would be the function of those sensory receptors? Well, those sensory receptors detect deformation of the base of the hair follicle, and any kind of deformation of the hair follicle will cause an action potential to be produced in these specialized receptors, and that information then is conveyed up these afferent fibers up into the spinal cord. So clinically, you may want to include, as part of your sensory examination, you may want to include different procedures or maneuvers that involve deformation of the hair follicle. For example, you can take your monofilament and not only touch the skin, the surface of the skin, which would cause a receptor potential to be generated in the Meissner's corpuscle. You may also want to drag your monofilament along some of these hair follicles to create a deformation of the hair follicle, which would test a completely different class of sensory receptor. Also in this same diagram, a little bit deeper down at the junction between the dermis and the deeper subcutaneous layer, we see Pacinian corpuscles. We see also all different types of receptive endings at the junction of the epidermis and dermis. We see free nerve endings there, which are capable of detecting any kind of tissue damage or deformation of tissue, particularly damage to tissue would cause response to the free nerve endings. So the long and short of this is there's many different types of receptive endings that we test with our sensory examination. Those of you that have the handout materials, here also is another diagram which shows some of the connections of the proprioceptive receptive endings, the Golgi tendon organs and the muscle spindles. The Golgi tendon organs are located at the musculotendinous junction, and the muscle spindles are located deep within the belly of the skeletal muscles. They're found within the intrafusal muscle fibers, and both of those basically do the same thing. They send sensory information to the spinal cord about changes taking place in the muscle, and that's information that our central nervous system relies on to tell us about the position of our body parts in space. And we have different examination maneuvers which we'll get to test the Golgi tendon organs and also the muscle spindles. Okay, so let's talk about some of our sensory examination procedures. Now, in the lower extremities, we said that we're not going to be involved in dealing with two-point discrimination. We reserve two-point discrimination testing mostly for the upper extremities and specifically for testing around the hand. And the AMA guides are quite clear in requiring that we do two-point discrimination testing for cases of carpal tunnel syndrome. So we're not as much involved with that in the lower extremity. With the lower extremity, we're going to be testing the sensory modalities of light touch and pain, and then to a lesser extent, and in the case of positive findings for light touch and pain, we may do some examination maneuvers to test joint position sense or proprioception. So let's talk about light touch and pain. With light touch, we are going to use examination instruments known as the Sims-Weinstein monofilaments. And if you have Sims-Weinstein monofilaments, you know what it is I'm talking about. If you don't have Sims-Weinstein monofilaments, you need to get those, because those are specifically described in the AMA guides as required for doing the sensory examination. And I know that clinically in the office with your own patients, your own treatment patients, you may not use monofilaments. You may use a wisp of cotton or the edge of a piece of Kleenex, or you may use these tiny brushes, small paint brushes. But the AMA guides specifically describe Sims-Weinstein monofilaments, so you're going to want to get those. A standard kit of Sims-Weinstein monofilaments includes 5 different densities of monofilament, and I think the 5 different monofilaments are approximately, I think they were about $150 when I purchased mine. And by the way, if you get and when you get these monofilaments, you want to take meticulous care of the monofilaments, especially the 2 smallest filaments. The 2 smallest filaments have a tendency to get bent and distorted if they're not meticulously placed in the carrying case that they come with. Because they're so small, they can get bent up and deformed, and they can maintain a deformed position and become basically broken. So when you get your monofilaments, you're going to want to take meticulous care, especially of the smallest 2 of the monofilaments. Then for testing pain, we're going to use the Wartenberg pinwheel, specifically the sharp side of the Wartenberg pinwheel. And then for testing another component of pain, we're going to use the dull side of the Wartenberg pinwheel. So let's talk about how to use these instruments and specific examination procedures for the lower extremity. Okay, so down in the lower extremity, if you recall from the AMA guides, that the diagram that showed the distribution of the sensory nerves in the lower extremity, you'll recall that there was many. And in the handout materials for this program, I've given you a template that you can include in your report that describes the report of findings of your sensory exam of the lower extremity. So we'll just go through these sensory nerves one by one and describe what normal findings would be for each of these sensory nerves. So beginning first with the lateral femoral cutaneous nerve, in describing normal findings to monofilament testing, your report would simply state that there is normal sensation to light touch at the lateral aspect of the thigh from the greater trochanter to the knee. That would describe your findings in relation to monofilament testing, which tests for light touch. For pinwheel testing and testing for pain, your examination your report of findings would simply state that there was normal sensation to pain at the lateral aspect of the thigh from the greater trochanter to the knee. So that's the pattern. you test first for light touch, and then you test for pain. This gives us a generalized look at the function of at least two of the different types of sensory receptors that we find out in the periphery. So you report your findings first as relates to light touch, and second as relates to pain. So for the remainder of this example, I'm simply going to report my findings as relates to light touch. However, you realize that you would also report your findings for your pain examination as well. Okay, so the next nerve that we would test would be the genitofemoral nerve. Your report would simply state that you had normal sensation to light touch at the anterior aspect of the thigh, over the hip joint, and to halfway down to the knee. That's the distribution of the genitofemoral nerve. The femoral nerve had normal sensation to light touch at the medial and anterior aspect of the thigh above the knee. For the posterior femoral cutaneous nerve, your report would state that you had normal sensation to light touch at the posterior aspect of the thigh from the buttock crease to the back of the knee. For the obturator nerve, you had normal sensation to light touch at the medial aspect of the knee to a point approximately 6 inches above the knee medially. For the saphenous nerve, you had normal sensation to light touch at the medial aspect of the leg, extending from the knee to the medial malleolus bilaterally. For the lateral sural cutaneous nerve, you had normal sensation to light touch at the lateral aspect of the leg, extending from the knee to the lateral malleolus bilaterally. And by the way, all of these are bilateral because you always want to test bilaterally. For the superficial peroneal nerve, you had normal sensation to light touch at the dorsum of the foot and over the anterior ankle bilaterally. For the deep peroneal nerve, you had normal sensation to light touch at the dorsal web space between the great toe and second toe bilaterally, and that's the first dorsal web space. Kind of interesting that the first dorsal web space is a pure patch of sensory distribution for the deep peroneal nerve. It's kind of like in the hand. The first dorsal web space is a pure patch for testing of the radial nerve, and there's a lot of parallels between the hand and the foot. Finally, for the sural nerve, we had normal sensation to light touch at the lateral aspect of the foot and along the fifth metatarsal bone bilaterally. Okay, well, what about the foot? Well, the AMA guides are specific in describing 5 sensory nerves, no fewer than 5 sensory nerves that provide sensation to the foot. And we've already discussed a couple of those, but let's say you specifically have a case that involves the foot. Well, the first nerve to test, according to the AMA guides anyway, is the medial calcaneal nerve. And your report would simply state that there's normal sensation to light touch across the bottom of the heel. It's the medial calcaneal nerve that provides sensation across the bottom of the heel. The medial plantar nerve provides for sensation over the bases of the first, second, and third metatarsal phalangeal joints and back to the heel. So if you test that and you find normal function, you would simply state that there was normal sensation to light touch over the bases of the first, second, and third metatarsal phalangeal joints and back to the heel. And recall earlier that we said that the medial plantar nerve provides sensation very similar to the median nerve in the hand, in that it covers the first, second, third, and even 1/2 of the fourth toes, similar to what the median nerve does in the hand. For the sural nerve, your report would state that you had normal sensation to light touch at the lateral aspect of the heel up to the lateral malleolus. For the saphenous nerve, you had normal sensation to light touch at the medial aspect of the arch of the foot up to the medial malleolus. And recall that the saphenous nerve is simply the sensory continuation of the femoral nerve, with all motor branches of the femoral nerve already given off to the quadricep muscles. That femoral nerve simply continues down as a sensory nerve known as the saphenous nerve. And then finally, in the foot, for the lateral plantar nerve, your report would state that there was normal sensation to light touch at the bases of the 4th and 5th metatarsal phalangeal joints and back to the heel. And just to analogize again to the hand, the lateral plantar nerve provides sensation in the foot, very similar to the distribution of sensation in the hand that is provided for by the ulnar nerve. Okay, so that is how to quickly test all of the sensory nerves of the lower extremities. And in your materials for this course, I've given you a template that exactly describes normal findings for each of these sensory nerves down into the lower extremities. Okay, so that's your sensory examination. You would just repeat those same tests with the pinwheel. In other words, you would test the pinwheel across those same sensory areas, and in the presence of positive normal findings, you would conclude that sensory receptor and sensory afferent nerve function is preserved. Okay, so that's the sensory exam. What about now the motor exam?